Hi, welcome. Hope you enjoyed Mike's talk on Introduction to Wound Care, and I'm going to carry that forward. We're talking about wound assessment, the basics. My goal here is to introduce you to how I assess a wound. I have two main reasons for doing this. One, so that you have a better understanding of what a patient experiences at their initial wound care visit or consultation. And two, my hope is that you can use some of these methods to assess wounds in your own practice. So let's get started. A good wound assessment is essential in that it reveals what factors are preventing wound healing and which ones are not. It helps to clarify what further studies are needed to best evaluate these factors. And then the treatment plan is just a natural progression of addressing each one of these factors. Unsurprisingly, wound assessment has four main elements that may look very familiar to you. We have focused history. The next part of that is doing a detailed, but again, tailored physical exam of the wound and also the features that are relevant for wound care. Next is initial diagnostic studies that we'll commonly perform at the time of the first visit, and then consideration for further diagnostic studies as needed. So for history, I came across this wound mnemonic in an article by Waters, and it was used for doing a whole patient assessment. And I thought it was kind of clever and also pretty practical. And then I wanted to add a few things to make it my own twist. So it's got an S and a T on the end of it. So it's Wunst. But anyways, let's go through it. W stands for what happened and when. So it's important to get a sense of, how long has this wound been there? It's a very different scenario if you've had a wound that's been there for a few weeks versus one that's been there for several years. And then kind of what happened to make it come about. So was this an injury? Was this started as an infection or pressure wound, or as a result of getting very swollen? Next, O stands for oxygen or perfusion. And so you want to take a look at factors that impact blood flow to this leg, both into the leg and out. So, does this person have a history of peripheral vascular disease? That's a really good question to ask. Do you have a vascular surgeon? Good chance that they probably have some vascular disease if they do. Have they had any interventions in regards to this stenting or angioplasty or any amputations or that sort of thing? For fluid management or edema, are they on diuretics? Have they had to wear some kind of compression device in the past? Do they have a history of lymphedema? Next, is there any history of smoking, as this can definitely impact the blood flow through vasoconstriction? U stands for underlying factors. A big component is how old is the patient? We all know that as you get older, healing slows down or it becomes much more difficult. We'll go into that more detail in other lectures, but it's good to have a sense of that here in the very beginning. Another factor is mobility. Can this patient reach their wound? If they can't reach it, how are they going to take care of it? How are they going to assess it? So that's an important factor. See if they have the social support to have someone do that for them is a good thing to do too. Psychosocial, do they have mental illness that prevents them performing, good self-care? Incontinence. Say this patient has a pressure ulcer and you've been able to relieve the pressure, but if you don't take note that they also have incontinence, this may keep the wound present there despite alleviating the pressure mechanism. A sneaky one is sleep. We all know that sleep is very important for overall health, including wound healing. But another factor to consider is how they sleep. Some patient may have a wound on their leg, and you're assuming that they're elevating their leg at nighttime when they go to bed, when in fact they sleep in a recliner and their leg is dependent 24 hours a day. And that's definitely going to impede your ability to heal that wound. N stands for nutrition. The two main things that we will screen for on a regular basis is to see if a patient's diabetes, if they have it, is under good control by looking at their A1C. The other thing that we like to watch very closely is their protein level. Protein is very important for wound healing. We see it as the building block for new skin. So we like to assess that as well through laboratory testing, and we'll go into that in a little bit. D stands for disease. Now, we've already alluded to diabetes. Disease also, or D also stands for drugs. And there are lots of diseases and drugs that can affect wound healing. So it's important to test for these comorbidities. So in addition to diabetes, you have a lot of autoimmune conditions like lupus or rheumatoid arthritis that can impede wound healing. There's some unusual conditions like calciphylaxis or vasculitis. In addition to these conditions themselves, there's also the treatments that are involved, which sometimes suppress immune systems, which impair wound healing. Patients could be immunocompromised for other reasons, such as if they have HIV or other hematologic conditions. Cancer in and of itself can cause skin lesions that fail to heal, such as squamous cell or basal cell carcinomas or melanomas. So that's important to keep in mind as a cause of potential wounds. Also, the treatment of various cancers slows down the healing process as it acts on rapidly growing cells like the skin cells. Likewise, for that same reason, radiation has significant effects on skin, both short-term and long-term, that need to be considered. Next is symptoms. I think it's important to get a good sense of how much pain this wound is causing the patient. This will affect their ability to clean and dress their wounds. And also, it's been shown that having high levels of pain impair wound healing. So getting a good sense of what their pain is and controlling it's important. The amount of drainage and the type of drainage is very helpful for picking the right type of dressing for the wound. And assessing for odor. Odor is often a very demoralizing and isolating feature of wounds. And if you can address that and treat it, patient and the family members will be very thankful. Lastly, another important pearl is to know what treatments have been tried already. Often at the wound clinic, we're seeing people, several weeks or months or years into their wound history, and to know what's been done already is very helpful. And what's been, particularly if they've had antibiotics, and if they had any improvement with it, if they've had any vascular interventions in the past, whether they be arterial interventions or venous, is very pertinent. Okay, let's go on to exam. At the wound center, we will measure all of our wounds, and we'll take a length, a width, and a depth, and we'll take that in centimeters. And we also take a picture of all our wounds because, while measurements are very helpful, pictures also display a lot of information that it's very hard to describe in words. We pay attention to the shape and the borders of wounds. We won't go into too much detail here, but for instance, arterial wounds tend to have a very circular and punched out look to them, whereas venous ulcers tend to have a very irregular border. And so this can sometimes clue you into what kind of wound you're dealing with just by looking at it. The level of tissue exposed, it's important to take note of. Most of our wounds will go down to the subcutaneous tissue level, but if you do have muscle or bone exposure, that denotes a more severe wound and requires special interventions. Getting an assessment of perfusion's much more reliably done with diagnostic testing, but you can get a sense for it on physical exam. Obvious signs would be dry gangrene for lack of perfusion, or if you had a cold foot, or there's a lot of pain, or you can't feel pulses. Swelling, it's good to get a note of how much swelling there is, as this is often a reason that leg wounds take much longer to heal than, say, if the wound was on the arm. Next is drainage amount and type. And as I mentioned earlier, this is very important for determining what kind of dressing you're going to apply on this wound. Signs of infection. Infection, as we all know, occurs along a spectrum. And so using the physical exam to kind of help you decide where you are on that spectrum is important. So looking for signs of erythema, purulent drainage, increased warmth, a lot of tenderness, lymphangiitis, abnormal vital signs. This can help clue you in on whether it's appropriate to manage this infection as an outpatient or inpatient. Necrotic debris. For example, on this picture here, we have a wound that on the anterior portion of the wound, or kind of the superior portion of the picture, the wound looks pretty good. It's got some pink red color to it, denoting some granulation tissue. But on the lower pole, or the posterior portion of that wound, it's got a lot of slough on it, which you can see is kind of like a yellow, green, gray color. That's probably a mixture of drainage, necrotic tissue, and bacteria, and that warrants debridement or removal to help with the healing. Lastly, getting a sense of sensation. We have a lot of diabetic patients. Do they have diabetic neuropathy, and doing an assessment for that? Also, we have a fair number of patients who've had some kind of a spinal cord injury and may be insensate. And that's important to note, as they will be much higher risk for developing wounds and not being aware of them. For initial diagnostic tests, for lower extremity wounds in particular, we're going to do an arterial assessment on their initial visit, and that involves getting an ankle brachial index, or an ABI. To refresh your memory, the normal range is 0.9 to 1.4. This assesses the larger vessels in the lower leg to see if there's any signs of lack of perfusion, and it kind of suggesting that there might be some significant stenosis that needs to be intervened on. Other ways to test it, there's a pulse volume recording, or PVR, that can be measured. That also looks at the larger vessels. And then in addition, there's TCOM and tissue perfusion studies that can also be done, that look at more of the smaller vessels and kind of give you a better sense of what the oxygen level is getting actually to the level of the tissue or the skin. Laboratory testing, the most common test that we're going to do is a culture swab. Wound biopsy is considered sort of the gold standard, and it's more reliable, but it also involves cutting and more pain or numbing. And so swab is usually done more for convenience and is usually sufficient. CRP and ESR, these are blood tests that we use to look for signs of inflammation, and then we use those in conjunction with the culture swab to kind of interpret those results. So for example, say we do a culture and we get MRSA, or methicillin-resistant Staph aureus. But when we look at the CRP and ESR for this patient, they're not elevated at all. And when we see this patient in the next visit, we see that the wound has actually gotten a lot smaller. It looks great. So we might conclude that, goodness, maybe this bacteria is just was a contaminant, or maybe colonized by the wound, but actually is really not impairing the wound healing process at all. And maybe we don't need antibiotics for this patient. Conversely, say we got a culture and it shows something that we wouldn't normally think is very virulent, like Proteus or Klebsiella, but CRP, ESR are elevated and the wound is not looking good, or it's stagnant, then we're going to be more inclined to treat that infection. Thirdly, we could have a culture swab that comes back negative, that doesn't really show any significant predominant pathogen, but the CRP and ESR are elevated. And that would make us concerned that we've had some kind of inflammatory process, say something like lupus or some form of vasculitis, that is causing this wound not to improve, and it's not from infection and warrants further studies. CBC, as you can imagine, can be very helpful for looking at the white count to see if it's elevated, to kind of see where you are on that infection spectrum. Every once in a while, we'll come across some patient who has a surprisingly low hemoglobin. We tend to see that more in our chronic renal failure patients. And if you have a hemoglobin of 6 or 7, that definitely can be a factor in why this wound is not healing. It just doesn't have the oxygen carrying capacity. Third thing is, every once in a while we'll come across really low platelets, the thrombocytopenia, and we'll need to kind of be aware of that, so that if we're going to do an extensive debridement, we may not want to do it in a patient that's got platelets less than 100. We'll be much more cautious. CMP, comprehensive metabolic panel, helpful to get a sense of where their kidney and liver function is at, so that when we prescribe antibiotics, we're not causing any end organ damage from that. And then next one is prealbumin. That's our test of choice to look at protein nutrition status. We have a goal of having 20 milligrams per deciliter or higher. You could use albumin too, but prealbumin is a little bit more responsive. It's kind of like the analogous to checking a finger stick blood glucose. You know where it is right away, whereas A1C is going to tell you what it's been like over the last 3 months. So both are useful, but they're a little bit different. Hemoglobin A1C, we like to use that to kind of get a sense of what the overall glycemic control has been like for our patients. If you have an A1C of over 10, you can be certain that this is playing a significant role in wound healing and warrants better control. Tissue biopsy, not something that we do a lot on the initial visit, although there are some instances where we see something that looks highly suspicious for cancer and we'll biopsy at that visit. More often, we're probably doing it maybe 3 or 4 visits in when we feel like the wound is not progressing the way we'd like it to or expect it to, and want to check for, again, any kind of a malignancy and/or autoimmune condition like a vasculitis that's impairing wound healing. Lastly, sometimes on the initial visit, we will order some x-rays. Most often, this is for our diabetic foot wounds that have been present for over a month. And the concern is that there could be either a foreign body or some signs of early osteomyelitis that we want to pick up on. Okay, finally, we've got some further diagnostic studies. So these are ones that maybe we'll be starting to consider ordering on the first visit, but we won't get these results back for a little bit of time. So I divided it up into 3 categories. We have vascular, infectious, and autoimmune oncologic. For vascular, by and large, the most common studies for ordering is an arterial duplex plus or minus a venous duplex. This is to look at the arteries and veins and see how they're functioning. If the patient is not a candidate for arterial duplex, can't tolerate it, then CT angio it can be used instead. Or if you have concerns about proximal obstructions, then CTA is going to be a little bit more reliable. There are some instances where angiogram will be sort of the first test you would go to. And that would be kind of scenarios where you have maybe a presentation with wet gangrene or wounds that make you concerned that they're at risk for limb loss. And so you'll skip the arterial duplex and just ask the vascular surgeon if they consider doing an angiogram up front. Next is infectious. CT scans are really good for looking for deep space abscess. MRI also can look for abscess, also very good for looking for osteomyelitis, which can be a cause for non-closing wounds or recurring wounds over bony structures. And also we use it to look for fistulas or intercutaneous fistulas. Nuclear medicine studies play a role as well, particularly looking for osteomyelitis. Most common scenario where we would use that is, say someone's had recent surgery on their back, say they had some form of disc disease and their surgical wound dehisced, and now we've got this deep wound that tracks near to bone, and you're worried that maybe there's some bone infection. If you did an MRI shortly after the surgery was done, you're going to see some reactive changes just from the surgery that it's going to make it difficult to determine whether that's osteomyelitis or just from the surgery. Whereas a nuclear medicine study, the TAG WBC bone scan study, is going to help you determine a little bit more clearly whether there's an infectious process going on. Lastly, we talked about biopsies earlier. Again, this is our treatment or our diagnostic test of choice when we're trying to determine if there might be some kind of vasculitis or malignancy present. And if we do see some abnormalities with the biopsy that's not malignant, then oftentimes we'll have our rheumatology friends help us with working up autoimmune conditions. All right, so now let's apply all this stuff to a case. And I picked just sort of this bread and butter case of a leg ulcer that we would be the most common thing we see in the clinic. Okay, so here's this patient's right leg, and let's start with some history. So for W, it starts as a scrape or abrasion to the right leg while gardening, and it happened about 2 months ago. Initially, it was really small. Now it's become much larger, and it's made an ulcer shape. For O, she doesn't have any history of vascular disease that she can tell you about. She doesn't take any water pills or diuretics for leg swelling, but she does have a history of some mild hypertension. For underlying factors, she is 65, but she's been previously very active, swimming 4 or 5 times a week, playing golf with her friends, and lives independently. So no concerns for mobility issues. For nutrition, she eats 2 times a day and is mostly vegetarian. For diseases and drugs, she has a history of type 2 diabetes and takes oral medications for it. Traits or symptoms. She has some mild pain, moderate drainage because she's having to change her dressing twice daily, but really not having any significant odor from it. For treatments tried, so far she's been washing it with hydrogen peroxide and applying antibiotic ointment 2 times a day, and recently completed a course of PO antibiotics with some improvement that she got from her primary care physician. For her exam, the wound measures 7.5 by 4 by 0.3 centimeters. She's got subcutaneous fat tissue exposure, but no muscle or bone. Her perfusion, she's got good pulses, 2+ to the dorsalis pedis and posterior tibial arteries, and her cap refill is 2 seconds. Swelling, there's definitely some compared to the left side, but it's relatively mild. Drainage is moderate. You can see that on the dressing that she took off when she arrived, and it's serosanguinous in nature. She's got some mild symptoms of infection with a little bit of erythema, but really no significant warmth. She's got a mild to moderate amount of necrotic debris. You can see on the top part, it's kind of pink, bottom part pretty yellow. And she's got good 2-point discrimination, so her sensation is roughly intact. Okay, so let's move on to some diagnostic testing. We do an ABI because she's got a wound on her lower leg. Results are 0.86 for her left leg, 0.93 for the right, which puts her in the normal range. Her PVR looks mildly abnormal, and I gotta say that's what I see most of the time in the clinic, unless I have a really young patient. So it looks pretty good. I'm not too worried about ordering a arterial duplex at this time. I am kind of considering about a venous duplex. Lab testing, her CBC has a normal white count. There's no anemia, no thrombocytopenia. CRP and ESR may be mildly elevated. Culture is pending at this time. For her comprehensive metabolic panel, kidney function, liver function looks normal, and her glucose is elevated though at 200. Prealbumin also could be better. It's at 15. Remember, our goal is 20. And not surprisingly, her A1C is 8. So because she's had this wound for 2 months, I'm going to order an x-ray just to make sure that there's no foreign body from when she was gardening and that there's no early signs of osteomyelitis. Okay, so let's summarize this patient in kind of a little nutshell. From the history, you know we've got a diabetic leg ulcer that's had some improvement with antibiotics. On exam, you see that there's necrotic debris, possibly some mild infectious signs still though, and some swelling. Initial labs are significant for a mildly elevated CRP, ESR, a low prealbumin, and a high A1C. Your initial vascular assessment, not really particularly concerning for arterial disease, so you'll probably hold on getting an arterial duplex, but you do see some swelling, so considering the venous duplex. So to kind of come up with our treatment plan, I definitely want to debride this wound to get it as clean as possible, get all that debris off of it. Once I've gotten it clean, then it's appropriate to get a culture. I'm getting x-rays because she's diabetic, it's had the wound more than 1 month, and I'm going to order a venous duplex just to see if she has any valvular insufficiency that's contributing to her leg swelling. For dressings, I'm going to pick one that's absorbent. I'm also, for her swelling, going to apply compression to help get that swelling down. Next, I'm going to encourage her to elevate her leg again to try and get that leg swelling down. And lastly, I'm going to stress the importance of glycemic control and protein for wound healing. And that'll be my first visit with this patient. So take-home points from this. I hope from this brief talk that you know what happens in general at an initial wound care visit or consultation. And I hope you see that how assessment helps to find reasons for for the failure of wound healing, and that the 4 main elements of assessment are, not surprisingly, history, physical, initial, and further diagnostic studies. How these lead logically to creating an effective treatment plan. And I hope that some of these things may be helpful for you in your own practice. Stay tuned. I think Kathy Ho is going to go over wound dressing selection in the next lecture. Thanks so much for your time. Take care.